Hey, good afternoon, dear network. It's exactly 14:30, so I think we can get started. And happy to welcome all you 91 participants to today's echo session. Specifically, or special welcome also goes to any participant that's joining us for the first time. You're welcome to the echo family. Feel free to just post in the chat box your name and where you're logging in from. Just indicate first echo session. It'll be good to know how our network is expanding. My name is Chipasha Mumbwe. I work in Western Province, and I'll be your facilitator for today. The topic for today is improving retention in pediatric ART. All those that are working in pediatric ART will agree that this is one of the difficult or one of the challenging indicators that we have in pediatric ART. And so we look forward to the fruitful discussion, suggestions, and the comments that will be coming through regarding retention in pediatric ART. We are fortunate to have Dr. Mando Phiri from DOD as our didactic presenter. He has a wealth of knowledge surrounding pediatric ART, worked for a significant time and continues to do so. And so we are definitely going to have a very good experience with him and looking forward to learning a lot from him. Apart from that, we have a panel of experts that is including pediatricians, pediatric focal point people at provincial level. We also have Pediatric Center of Excellence attendees. These are people who've been working with pediatrics and adolescents for a while, and so they will definitely have a lot to share, a lot of input to give on this subject matter. So please feel free to post your questions even in the chat box. Don't wait to unmute and speak. All these experts are available for us to tap in, share our questions and our comments with, and they'll be able to guide us. So just some echo etiquette before we start. Kindly ensure that your mics are muted, and you also switch off your videos. Unless you're on the floor, please don't unmute to speak. If you have a comment, if you call for comments or questions, just raise your hand. We'll be able to see it and we'll give you an opportunity to speak. As I mentioned, it might not be feasible for everyone to unmute and give a comment or question. And so that's why the chat box comes in. You can put your questions in the chat box even as the presentation is going on, and someone will definitely come through to answer your question. We're also encouraged to, in case you have issues to vote when the polls are launched, you can feel free to comment with your answer in the chat box. Remember, this is a non-judgmental platform. We are all here to learn and share experiences, and so don't feel ashamed to post your comments or your answers in the chat. Okay, with those few remarks, I think I'll hand over now to our didactic presenter, Dr. Mando Phiri, for the didactic presentation. Over to you, Dr. Mando.
Okay, thank you very much, Dr. Chipasha, and it's a pleasure to be with everyone on the call. If you can just confirm that my sound is clear, then I can begin.
Yes, Doc, we can get you clearly.
Okay, so thank you very much again. So my name is Dr. Mando Phiri. I currently working with CIDA and in a DOD project in Central and Western. So it's a pleasure to be with you. I don't have any disclosures or any conflicts that I need to address. And today we are an interesting topic that we'll look at, and we hope that we can do it in good time. So it's pediatric retention.
Dr. Mando, we can't get you.
Hello? Is that better?
Yes. Yes.
Okay. I mean, I've lost you at some point. Okay. So I meant that these are our objectives, and there are 4 of them, and then we'll address each one of them as we go on. So retention is a process of maintaining a client or recipient of care and treatment, whatever treatment that it is. And mainly it is monitored in the early progress between 2 respective periods. Okay, so, but it can also be done on a monthly and a quarterly basis. So retention can be affected by what is termed as retention, as attrition, sorry. So yeah, can be affected by what is termed as attrition. So there are clients that we call as late clients. So these are clients that have just missed their appointments and then need to be followed up almost immediately. Okay, so then there are those that are interruption in treatment. There are people that have been missing from the system or from care for at least 28 days, and others do say about 30 days. And then there are those that are defaulters that actually say, I do not want your treatment. I don't want to be part of your TX car for whatever reason. And we look at some of those reasons. And there are those that we do not know where interventions have not been completed and we wish to complete these interventions. Okay, so some of the causes include interruption in treatment, like I already talked about, and these can be less than 3 months, 3 to 5, 6 months. There are those that die. You would have lost those clients and they affect our TX card. There are also those that are going to trans out and leave for genuine reasons, transfer out, go to seek other opportunities. And there are those that refuse treatment, our treatment, for whatever reason that they may have. Specifically for pediatric ART, we see that some may actually go to the next age band, and you tend to lose those ones from your specific TX car. So that's called aging out. And then there are those that we have unknown causes. We are not able to track them because they are wrong addresses, wrong phone numbers, and so on and so forth. So here's a slide. To the next 2 slides, we just describe what's happened in the province, not necessarily in the DoD project, where this data comes from Lusaka, Southern and Eastern and Western. So we see that some of the clients that are termed as silent transfers do re-engage in some of our facilities as new clients. So of the clients that were identified, it's about 17,000, 18,000 people. About 59% reported themselves as new clients. So these are clients that say, hey, I'm a new client, please test me. They will test them, and then they get engaged in treatment. So this is one of the parts. And we see that our adolescents and pediatric clients, about 52% and about 69% for the adolescents did say, yes, I am a new client. Please enroll me into your TX card. But in actual fact, they actually just silent transferred into your facility. So this is the annual IIT for all ages. And we know that if a child moves, an adult moves, because most of our children are in care of adolescents, older adolescents. They're also in care of most of our adult HIV clients. Okay, so we see that here Lusaka and Eastern having quite a big number of clients that they are losing for various reasons. Okay, now here's another TX card analysis coming from a presentation that was done at one of our meetings. Is that about 4.1% of our clients, those are pediatric clients, are going to or aging out into the 15% age group. And then about 18% are aging out into the 21, 24, 25 years plus. And we see that this number is really affecting the pediatric TX scar. And as we can see from this little box here, even as much as we are finding more clients, we are actually edging out more clients between those ages. So we found about 3,100 clients, and then we edged out 4,400. So that's a negative gain on our part, even though we're doing quite well. So what reports can we do to identify or to see whether retention is happening before we actually see what are some of the causes? So there are a couple of reports that we can look at, and these reports include what is called a comparison report. So you usually compare two reports, one period to another period. So let's say, for example, you want to compare March with February, or March last year to February this year. So those are some of the clients that you would see. So we have used two reports called the QAQI reports. These are PEFA MER reports. And then you can also use a comparison report in Smart Care Legacy called MER comparison report, which is a very good report in Legacy. So you identify clients that were in the TX scar then, and see which ones have actually dropped off during that time. Okay, so others could actually use physical counts of files to make sure that you check every client, and then you also analyze losses and correctly categorize them, and you see most of this. Okay, so some of the causes of interruption. So client-based interruption causes or causes of interruption are self-transfers, where a client just decides to leave the facility without actually communicating with the facility. And then they temporarily access treatment at another site, they have a business, or they traveled with their mother, they went to boarding school. One site you are accessing treatment, but you are actually lost at your mother's site. Death and not reported at the facility. So others, we have seen that clients would actually share drugs, or siblings would share drugs amongst themselves, even share drugs with their mothers and parents and caregivers. At one site, they are actually lost, but they are not accessing treatment in theory at their mother site. Okay, so others are system errors, which includes updating of files. You know, with ELAS, you have to manually update these files. And then there are those that others we as healthcare workers, we delay to disclose or initiate the disclosure process, and this leads to people not or adolescents actually lashing out and stopping to take drugs. And then we also have transfer on MMD or multi-month dispensation, where at one point a client is considered as having still have some drugs in the system, but lost at another site. Okay. Others are losses and mortality. So malnutrition is a very big cause. TB, malaria, and also diarrheal diseases are some of the causes that we'll need to worry about and also intervene. Okay, so just a quick question, 4 questions for us to answer. Okay.
Okay, thank you, Dr. Mando.
Yes.
Go through the poll question 1. Mutala is a stable adolescent on 6 MMD accessing treatment at your facility. A month after her last dispensation, she requests a transfer to another facility, and you decide to transout immediately and link to the next facility. Is this a correct decision? We have 2 options there. There's a yes or no. Okay, we'll wait for the polls to be launched, and where we can, okay, they have been launched, and we can go ahead to maybe IT just kindly look at the question that has come there. It seems different from the one I'm from reading. Can we still proceed?
Yeah, so maybe IT can guide us whether we continue or we can edit the question later?
Please continue. There seems to be a mix-up with the polls.
Okay.
Okay.
Okay, thank you.
Okay, though, I'll read the question again. Since we have true or false, we'll take it that the true is a yes and the false is a no. I don't know what you think about that, or we just skip this question.
Yeah, so it's we can still have some responses here in the chat. T
Okay.
for true or yes for true, Y for true, Y for A, sorry, then no for, yeah, can do that quickly.
Okay, so kindly post your answers in the chat box. We just have a slight glitch in the IT section, which we hope will be corrected. I'll repeat the question. Muntale is a stable adolescent on 6 mmD accessing treatment at your facility. A month after her last dispensation, she requests a transfer to another facility, and you decide to transact immediately and link to the next facility. Is this a correct decision? So you can post A for yes or B for no. Okay. Thank you. I think we need to move on to the next slide. So thank you.
Okay, thank you very much. Okay, so we'll look at some of the best practices for making sure that not only adolescents, but including older clients and other family members. Okay, so appointment management is one of the key things that needs to be put, and various programs have various ways of how they do this. So one of them is a prior reminders, and then we'll look at what each one of them are. Systematic review of clients, peer pairing, family-centered weekend clinics, social and the scholar models, amongst others that can improve retention. So others include, death is one of the things that would affect clients being on treatment or remaining in treatment and not dying. One of these is making sure that TB is treated, malnutrition is being monitored, interventions like OVCs are being put in place, and also septrin that will prevent death is being given. Okay, so what do we mean by a systematic review of the client file? So if you look at your system, either SmartCare Plus or SmartCare Pro or even SmartCare Legacy, even those that are using ELAST, you need to review this client's file. Is the dose correct? Is the weight correct? Is a viral load due? Okay, so because those will help you to make a decision for this particular client to come back in good time. So always check the client details at every visit, which is in 6 months or in 3 months. Ask, have they moved? Have they moved to the next facility? Because this will help you correct the address that has been lost, okay, or that has changed, okay? And always ask about disclosure for each of these clients. Okay, we know that our adolescents and young clients will need to start disclosure quite early, and we'll look at the process of how to do that. So here I just showed a small example of what can be done. You will have to look at your system and make sure that your client is doing quite well in treatment. So you have patient reports and SmartCare Pro, SmartCare Plus. The reports actually come in a section called reports, and you can actually pull out some of those reports, check your viral load, check your TPT, and the rest. Okay, so appointment reminders. So you need to generate an appointment reminder at least on a daily basis. If this is not possible, at least on a weekly basis, and scheduled in respective days where you know that clients are supposed to come on on this day and also entered into the appointment register. Okay, so the appointment register is supposed to reflect the clients that are going to come, not necessarily the clients that have come. We have seen some of those as gaps in our facilities. Okay, so one other thing, there's a register. On the CDC end, we don't have this register, but on the, I think on the other end, especially the DoD sites, we have the register called the 7310 register. So this 7310 register looks at reminding clients. So you have to tick, I've reminded at 7 days, I've reminded at 3 days before arrival, I've reminded the day before arrival, and on the day of arrival or of the visit, you'd actually remind this client. So it's called 7310, looking at those specific days when they're supposed to come. Okay, so other stuff that need to be, so these reminders should be done at least a day before. If you get stuck with everything, at least a day before, so that you know when you're supposed to come, but ideally 7-3-10. And then reminders and missed appointments need to be done immediately at the end of the day. We know that at the end of the day, we are expecting 10 clients. Of those 10, 8 came. Those 2 that have not come need to be communicated with the, one other good part that needs to be put there is disclosure. Okay, so disclosure is key for adolescents to remain in care, for our pediatric clients to remain in care. So you can start this disclosure process as early as 5 to 7 years. Okay, 5 to 7 years. I won't give all the details that need to be there, but 5 to 7 years, and this can actually be found in your ZCG on page 85, 87. So if you can look that up. So early disclosure is when you start at around 5 to 7, and here you just you're not mentioning HIV. You're just introducing good and bad health and how medicines actually help you to help the child or client to do better in terms of health. Then there's what is called partial disclosure at 8 to 11, around 8 to 11 years old. Would start what is called partial disclosure, and here would explain. By this time they're in grade 1, grade 2, grade 3. They know what a germ is. They know what causes diseases. For those that are going to school, but even others can also be explained. Oh, there's actually a germ that does this, that affects you, and this germ is actually a clever virus that needs to be treated with the medicine that you are taking. Okay, and the medicine needs to be correctly taken. Okay, so others, you need to, those are 15 to 14. So by this time, we should have actually started to make sure that disclosure is that full disclosure. They know what the disease is. They know that it's a virus. They know that it's the medicine they're taking in ARVs, and they also need to be sexually aware that they can actually transmit this HIV or the disease to someone else, because they become sexually active around that point. Okay, so this process needs to be agreed with the caregiver. It doesn't have to start from the clinician. So you agree with the caregiver, when can you start this? And then you agree on points when we can start. Okay, so we can go to the next poll.
Okay, poll question 2. Peter is an 11-year-old child living with HIV at your facility and on wishes to enroll him on 6MMD. What is your next best step? Okay. Immediately prescribe 6MMD, that's A. B, check client's weight, VL, TPT, contact details, and if eligible, provide 6MMD. Advise mother that client is not eligible for 6 mmD. Repeat, Peter is an 11-year-old child living with HIV at your facility and on 3 mmD. The mother wishes to enroll him on 6 mmD. What is your next best step? A, immediately prescribe 6 mmD. B, check client's weight, VL, TPT, contact details, and if possible, provide 6 mmD. C, advise the mother that the client is not eligible for 6 mmD. Okay, so as we did before, if you're unable to vote using the polls, kindly send your... Okay, this poll is actually okay now. So we're encouraged to use the poll to vote. But for whatever reason, if you can't access the poll, feel free to comment in the chat with your answers. So far it seems we have B leading, because in the poll, 3 seconds.
Yeah, we have about 60% that have voted so far. So.
Yeah. Okay, so this is how we have voted. 92% have voted for option B. I'm sure Dr. Mando will be able to run us through the polls later.
Yes, we will do that. Okay, thank you very much.
So we just have about 5 minutes, Dr. Mando.
Yes, I'll do that quickly. Okay, so so appointment optimization is a process of providing all the services within the same space. So we need to, this improves retention, this improves collection of viral loads, improvement of other services that we need to look, and then we need to align all the clinical and laboratory appointments into one service. So for children, like in our question, every child that is at least 2 years can be given some form of multi-month dispensation from 3 months to 6 months, and these need to be stable and need to be suppressed. At least disclosure should have started for this class. So in our example, we'll look at how that is. DSD models are also models that help us maintain our clients' care, and usually they follow this system: when, where, who, and what. So we look at when is it going to be provided, where is it going to be provided, who is going to provide this service, and what are we providing there. Okay, so we'll look at some. So weekend clinics, the when is on the weekends, and these look at children that are going to school, pupils that are going to school, and then those that have caregivers that are not able to make it in good time. And we provide all the services that can be provided: lab services, GMP services, drug collection, and all VC meetings, and can be incorporated into adolescent meetings and peer meetings, okay, where they meet up, they discuss. Okay, they are best done with an appointment, so that you know how many are coming for that day. Okay, but if they are not there, even walk-ins can be allowed for you to better the system. Scholar models are models made for those that are going to school, that are in boarding school, for the older adolescents. And then here we are actually going to call them during the holidays, provide the services that we need to provide. All of them usually in the same holiday, so that you space them, that the next time that they're going to come during the holiday, the next holiday. Okay, and these are held at the same time with adherence and other sexual and reproductive health services for the adolescents. Okay, so quickly on 4.3, so that we can end.
Okay, so for question 3, Toela is married, pregnant woman at 34 weeks, and the mother of 2 children who are living with HIV. Your facility has a dedicated Monday Pediatric clinic and Thursday MCH clinic. Which is the best care for her family? A, for privacy, Toela should be seen on Thursdays, EMTCT services. B, her children should be seen separately on the Monday Pediatric day. C, all family members should be seen on the same day in the MCH department. Please, let's vote quickly. We have the poll already launched. I'll read again as we wait for more people to vote. So just around 30%. Toela is married, pregnant woman at 34 weeks, a mother of 2 children living with HIV. Your facility has a dedicated Monday Pediatric clinic and Thursday MCH clinic. Which is the best care for her family? Please select the 3 dots at the end where it's written more, and then you will find an option saying pause quizzes. The poll has actually been launched. For privacy, Toela should be seen on Thursdays EMTCT services. B, her children should be seen separately on the Monday pediatric day. C, all family members should be seen on the same day in the MCH department. Okay, so at least we are at 57%, just crossing the 60% mark. And the pause here. The majority have voted C, Dr. Mando, that's 89% of those that actually managed to vote.
Okay, thank you very much, Paul, and I hope that we are actually practicing what we are saying here by the polls. Okay, so quickly going through, so there are other services that help retention to get better, to be better. So these include treatment support, and these are persons that are supported through emotional support, some treatment support, some social and financial support to help them through the journey of their treatment. So some of the methods that are there are family-centered approaches. So this is similar to what our example was. Okay, so family-centered approaches, members are seen together in the same unit, in the same space. Okay, so for example, in our unit, you see that the mother, everyone is seen in MCH, and our MCH services should be able to provide all the services for the children, at least for the adolescents. Okay, so that some of the benefits include caregivers who come fewer times, viral loads, pharmacy appointments will be done in good time. Okay, others is who is supposed to be seen. So this will be a young adolescent or child less than 15 years old. You know, with our young, slightly older ones may not want to be identified in the MCH or going to MCH. So rather the younger ones are the ones that are there. Okay, so family members can also support each other during those times when they're coming to the ART services, and then we can also discuss things like disclosure, and do adherence support. You can also look at families that can take the medication at the same time. Okay, and then discuss also on transition to adolescent or adult ART clinics. Okay, so peer pairing. So peer pairing is where you have 2 individuals. One is an engaged person who's maybe a community healthcare worker or an experienced client that is paired with another recipient of care who is on the TX card. Can be also from a different TX card. Okay, so these are people that will access treatments, and most of them are mainly for disclosure purposes, and disclosure should have actually started. We don't want to accidentally disclose to this client. So peer pairing should have actually, disclosure should have actually begun before peer pairing. Okay, so even high viral load clients can actually be paired with these peer mentors. Okay, so you have an experienced adolescent that has been accessing treatment for a long time. They have undergone through these processes of not taking medication, and so on. And then they can actually be brought in now to support this adolescent that is having issues taking medication. So also a special type of a peer mentor is a mother-to-mother, mother mentors, which we'll talk about just in a short bit. Okay, so some special peer mentors are mothers to mothers. These are trained is to provide care for HIV positive pregnant and breastfeeding mothers. They can also be new clients. In case of new clients, high viral load clients, and also caregivers that are taking care of HIV positive children, okay, or HIV exposed children, positive children. So these are caregivers, not necessarily them being on treatment. So what is the role? So the role is to support adherence, also appointment reminders. Sometimes you can do some drug deliveries. If they are not able to come, they can also be linkage to support services. You can also link them to support adherence or dots if you want. Okay, so mainly this happens for these peer mentors. This happens in mother mentors happens in MCH and can also be done with SMARTs where mother mentors are not there. Can also be done with a healthcare worker. This is a CHW, a community healthcare worker, that is at least on a stipend and that can help HIV positive mothers and other mothers, caregivers that are providing services. So orphans and vulnerable children. So this is a whole different program that's there to support how adolescents and children are accessing services. So this OVC services and Sungani Vana initiatives, this SBI. So this looks at making sure that the children are stable economically, they are healthy, okay? There is no violence in their homes, and then they are also schools. They are provided with some support to make sure that they are going to school. You know that some of the challenges that some of our adolescents and children may face is that, oh, I don't have the opportunity to go to school. My parents cannot afford, so that is provided to them through the school support. Sungani Vana may not provide all these, but it provides stable, it provides some health, it provides a healthy platform. Okay, but obviously provides all the four elements highlighted here. Support groups, very essential, because you know when you have to discuss with others, you are better off the person that has actually gone through some of these experiences. And they are better done when they are broken out into two groups or more. Okay, so you have those that have similar characteristics, like 10 to 14 and 15 to 19, so that they are meeting at different points and discuss things that pertain to their care and to their well-being. Okay, caregivers can also be grouped to have these support groups, especially the HIV exposed, that are caring for younger children. Yeah. Okay, so summary of points. We need to make a systematic review of each client that comes to our health facility. Retention looks and presents how quality or how our services at the health facility are. If you're losing a lot of clients, then the quality of service that we are providing, as the good work that you're doing as a health facility, may not be appreciated because you're losing more the clients. Okay, there are other ones that we can accept, like transfer outs and so on, but losing a client because your address was not collected correctly, or the client just decided to move out without communicating. IIT is preventable with recipients of care that are engaged and good appointment system. All family members can be seen on the same day at the same facility or in the same department. Okay, do not forget about top causes of death amongst pediatrics. That's malnutrition, TB, malaria, and also diarrheal diseases, which can be preventable to make sure that our clients are doing well on treatment. Over to you, Dr. Chipasha.
Oh, well done, Dr. Mando. Thank you so much for summarizing this complicated topic. Yet you managed to actually bring out the important points that we need to learn from. We're going to invite a set of questions. Maybe we can do 2 or so. At the same time, I'm going to ask that Changwe Luckson from Pumba Rural Health Center, Lavushimanda, Muchinga province, just gets ready to share your presentation with your team. If you have issues sharing, please let us know quickly so that IT can assist from the hub end. Okay, so for those that have questions to the Didactic presenter, Dr. Mando, kindly raise your hand so that you can be given a chance to actually ask your questions. We can see if we can entertain two on the call. Any questions, please? Yes, Kafula Mwanga, kindly unmute.
Okay, my question is basically going to the last question that we had in the discussion. This mother is a HIV positive mother, and she has two children who are also HIV positive. Then again, she's pregnant. What are the chances that this coming child will come out negative? Thank you.
Okay. Yeah, thank you very much, Kafula. So the chances are very good. You know, with the modern medicine that's there, we can actually have almost zero transmission to this child. Okay, viral load is at zero or undetectable. All the necessary prophylaxis is given up to 12 weeks. Okay, the possibility is that this child can actually be HIV negative at the end of the breastfeeding period. It's very, very possible.
Okay, Kafula, I hope your question has been answered. So we also have a hand from Dr. Muka Choka. I hope I've pronounced your name correctly. I'm sorry if I haven't. Please unmute and give us your comment. And as I said, please feel free to ask your questions. You can post even in the chat box. If you're not comfortable unmuting and letting everyone hear your voice, we can actually read out your question in the chat or your proposals or solutions. Thanks. So Dr. Muka Choka, please give us your comments.
Thank you very much. I think I had typed it in the chat box. For the clients that move to other facilities, is there any other way of verifying that they've never been treated? If they come to us and they say they've never been treated or they've moved from a different facility and they have no ART number, how can we then verify that they've never been treated?
Okay. So I have, I'm sure there's some other panel of experts there.
Yes,
but
please, I was actually about to say the same, Dr. Mando.
Okay.
These questions are not just for you alone. Please, our experts, or anyone who would actually like to attempt this question. Dr. Muka, just to be clear, you said the client doesn't have an ART number, but they present to your facility and they claim they were picking drugs somewhere. Did I get the question correctly?
The question was that they claim not to have an ART number and they claim to not have a history of ever picking drugs from anywhere. So they appear as a new client. So is there any way to verify?
Okay, your facility tested them.
Yes. And they claim to be a new client.
Okay, thank you. I can see Dr. Chimwemwe Zulu's hand is up. She's one of our panel of experts. Dr. Zulu, please come through to help us with the question.
Maybe as Dr. Zulu is coming through, I think one of the things that have been put in place to, Dr. Zulu, can go ahead.
Okay, thank you. Sorry, I was failing to unmute. So good afternoon, everyone in the hub. Good afternoon, everyone on the call. Thank you very much for that question. So what I'll say is that what has been noticed so far and where we are getting a lot of silent transfers is one of the verification, not really verification, one of the indicators is patients who are coming to us as new clients, but when you do your baseline viral load, you find that they are undetectable. So these have been the clients who have raised a lot of concern, because you expect for someone who has a new HIV infection, the viral load should be to the roof. So if you have someone who's undetectable, that's the first clue, so to speak, that there could be a silent transfer. But then you have to counsel these clients, speak with them well, so that they're able to reveal that they truly are an old client who's been on treatment. And only when they accept is when you can now say, okay, this is an old client, but it's a struggle. I think what is trying to be done is to look into how can we prevent these silent transfers, because as you saw from the presentation earlier, I think Dr. Mando had mentioned that in pediatrics, about almost 50% of the new clients are silent transfers, which is quite high. Yeah, so I think more work needs to be done on the counseling processes. How do we speak to our clients? How much do they trust us? So that even when they trans out or move elsewhere, we're able to find them. And when they come to us as new clients, they're able to be free to express themselves. So I think this is a hot topic, as well as the issue of baseline viral load being undetectable for new clients. I think those are my thoughts on that. Thank you very much.
Thank you so much, Dr. Zulu. And that's well elaborated. And I think she has covered almost everything that is being recommended regarding how we are handling such cases. Your pre-test counseling will really matter a lot. And that's where we have the KP screening tool also applying. We talk about it a lot. Overall, as Dr. Zulu has mentioned, how comfortable are we making our patients feel? Because most of the time they are kind of withholding the truth because they feel we're going to chase them back or chase them and ask them to go back to their facilities. So they feel it's better if they claim they've never been tested, so that you find them positive and then you put them on your TX scar. And then once we get our baseline viral loads, that's the part where we now have the reclassification that we need to do. If we find the viral load is suppressed, we have to re-engage the client and try to get them to, in a non-accusatory way, but try to get more information about whether they have actually accessed ARVs from other places before us testing them at our facility. Okay, thank you, Dr. Moka, for that good question. I think I just saw a comment in the chat, wasn't necessarily a question. I will allow the last two hands to be from Enoch Lukulu Dap and Kazadi Kashikula. Kindly give us your comments. Mr. Enoch, you can go first. Then we proceed to the case. So just a reminder, Mr. Changwe, can you please share your case as we are getting the last two questions or comments?
Thank you very much, Dr. Chipasha. I wanted to find out from the team in case of children modification on the drugs from the 3-month to 6 mmD. At what point do we recommend a child from the do we switch the child from the 6 months mmD to 3 month or rather lesser than the 6 month mmD? And what recommendations should we have in place for us to reclassify the child to those levels of modification?
Did I get the person asking the question? You want to classify them from 6 to 3, or is it in the reverse?
It's the same.
3 to 6.
No, 6 to
3. Okay, I haven't come across any reason why you should reclassify such a one, except those ones that either get pregnant, okay, one, that a client that gets pregnant, or a client that for some reason maybe they're not adherent, you would push them to a monthly prescription rather than a monthly, a 3 months prescription, unless others have had something that is quite different. But usually once you give 6 months MMD, we don't go back to that 3 months MMD.
Okay, thank you, for that question, and Dr. Mando for the response. Kazadi, kindly come through with your comment.
Okay. Thank you so much for the opportunity, and thank you for our representative and all the participants for this informative component that has been given to us. I have two clarification to have. One of them goes back to the question of Dr. Muka, who wanted to see and to know how discriminate whether this is a new HIV infection or this is you have been on treatment for a long time. I just want to know if recency testing, the way we do it in adult, has a room in discriminating old patient and new patient. That is number one. And then number two, in the presentation related to pediatric retention, it was exposed that one of the causes of loss of patient is to refuse treatment. So here for patients who are refusing treatment, is it that patient is already on the TX car and refuses the treatment? The patient who have already enrolled in ART care who refuse treatment. Finding somebody who refuses treatment before being part of a TX car will rather affect our linkage and not really impact negatively our TX car. So I want just that clarification on this refusal of treatment. Is it at inception, or it is a patient who has been on treatment who later on refuses treatment? Thank you.
Okay, so just starting with the very last one. Yes, it's the client that is on your TX card and refuses your treatment. Maybe they went for some miracle work of some form and they thought, no, stop taking your drugs, and then they refuse your treatment. So that's one example that would have that. Then in terms of recency, for new client, you can actually be a new client, but your baseline might be high. Baseline viral load might be quite high, but you are no longer a recent infection. You are infected 5 years ago. You will not be a recent infection. And if you look at your algorithm and notes on recency, less than 15 do not qualify for recency. So that would be somewhat where we don't bend towards for children.
Okay, thank you so much, Dr. Mando, for the responses and the questions. Kazadi, I'll ask Dr. Mwinga to finalize this session for us as we proceed to the case presentation. Dr. Mwinga, please come through.
Thank you, Chair. And I just wanted maybe to re-emphasize or re-echo. I don't know if these points were mentioned. I had dropped off the call because of internet. But I think people did ask important questions on the issue of silent transfers and what can be done at facility level. So we do have facility level intervention, system interventions that can be put in place. And really it's a worrying issue now because we are failing to grow our TX car because it's the same people that we are finding as TX news that we are re-engaging into care. So for me, I think it starts from customer care. So when someone presents as positive at a site, I think it's the way we engage the clients, and key to the customer care training or customer care handling of the clients when they're at their site is the counseling that we give. And we should be open about it, that they can access ART anywhere. We should not restrict them with just our facility. So in the counseling, if we are telling them that they can access ART anywhere in the country, for as long as they present themselves as someone who's already on ART, and they can actually mention in the facility where they are getting the ART from, the service should actually be provided to them without any reprimand. So we partial as healthcare workers created this challenge where we sort of have to force the clients to say, come to this facility because this is where we started you on ART from, and you should always get your ART from here. But that's not the case. So many things happen, and the clients should actually be forearmed with that information that they can access ARVs anywhere in Zambia for as long as they have actually openly declared that they're on treatment. But then coupled to that as well, there's a non-positive screening tool that you can use to try and ask a few leading questions, which will actually point you towards whether the client is actually experienced with the ART. So there is actually a nationally approved non-positive HIV screening tool. Then, of course, baseline VL is a surrogate that we are using for those ones that could be on ART if someone presents as TX new and they are suppressed. So we are taking that as a surrogate measure to say that they are really not naive to treatment, their experience, they are on ARVs. So those are the ones that we are using. But then there is a biologic test, though that one is not yet WHO pre-qualified, and that's why we are not using it. And but it's still being used in research settings where you can actually get urine and test for TDF metabolites. But going forward, that one might not be here maybe in this year or the next year, but it's something that we are looking forward to. But then going forward, currently, what is it that we are putting in place to try and address that issue? So we have Smart Care Pro that has a biometric embedded in there. So with that being a web-based a platform, and of course to have to currently, I think when you look at the sites that are earmarked for rollout, it will cater for about 80% of the TX car. So really for any patients who move from facility A to facility B just at the click of a finger or any biometric that will be embedded in there, the receiving facility would be able actually to tell that this individual is already on ART. So I think those are some of the measures that are being put in place to try and address that gap. As is, it's really a genuine concern, and we sort of need to put our heads together at facility level to ensure that the counseling and really the use of the non-positive screening tool as well is up to speed to ensure that what we end up reporting as TX news should really be the true TX news, as opposed to the current scenario where it's people that are moving from facility to facility as silent transfers or as passers-by that we are reporting as TX news. So yeah, really we need to sort of put our heads together and look into that. Yeah, over and thanks, Chair.
Thank you so much, Dr. Mwinga, for that well-summarized valuable input that you've given us. Mr. Changwe Luckson, kindly proceed to give us your presentation, and please try to make it within maybe 5 minutes, but make your important points come out so that we are able to advise correctly on the questions that you're going to ask. And please just make time to just read through the chat box, as some of our experts have actually also commented on the questions that we were asking. Over to you, Changwe Luckson and the Mumbwe Rural Health Center team.
Okay, thank you very much. My name is Luckson Changwe, HIV nurse practitioner from Mumbwe Rural Health Center, Lavushmanda District, Muchinga Province. Okay. Okay, so on our case, we have RN, female 10 years of age, who was born on 15th of June 2013, RVDR on CAT for 2 years. Started treatment on 13th of April 2021. The child lives with a very mobile father, non-recipient of care with excessive alcohol use, 2 siblings as well as the grandmother. So the father accessed drugs at Mumbwe Rural Center as a passerby on 2 specific occasions, during which he said he was accessing care from Mukushi district. The mother died in 2021 from suspected AHD, which was a suspected severe HIV wasting syndrome. So after the mother died, the child and her siblings were taken by their grandmother back to Lavushmanda and requested that all the children be tested for HIV. So when RN was tested on 13th of April 2021 during community testing, and she came out positive, while the other two siblings were negative. So on drug history, we have was started on ABC3TC, LPVR, INH, and then switched to ABC3TC Pediatric DTG on 24th of August 2022. So the father remarried in Lusaka, then came back and picked up all the children from their grandmother and settled in Mukushi. So while they were in Mukushi, RN was said to have defaulted treatment as the stepmother never used to give her drugs. So it is believed that RN's father only stayed in Mukushi for a duration of 1 month, and due to some economic hardships, misunderstandings with the wife, he decided to return to Mununga with all his children. So when RN came back for a DO appointment, the viral load was 1,845. Despite having been enrolled on EAC, the caretaker, which are the grandmother, as well as the stepmother, were not giving the child medication as instructed. So during this period, the child was constantly moving between the grandmother's place as well as the stepmother. So the adherence was somehow a challenge. So this was discovered after post-EAC VL was collected, and the result came out as 22,927. So extended EAC was restarted. The grandmother was, sorry for that, the grandmother was, extended, then the grandmother was cancelled on adherence. Then on 24th of August 2022, the post-EAC VL came out TND. Again, on 24th of November 2023, that is more than a year now, the viral load was 236,772, and the major barriers during this time was that the child was being given incomplete regimen. The child was receiving DTG alone. So this was discovered when the professional counselor visited the child. So in absence of the grandmother, the other caretaker was used to give the child the medicines. So after EAC again, the viral load latest is at less than 40 copies. Yes, less than 40 copies as of 28th of March 2024. So examination as of 24th November 2023, the child still looked healed. The temperature was 36.9, the respiration was 26 breaths per minute, the weight was 20.6 kgs, height was 119 centimeters, and homework was 15. So the plan of care at this particular time was that to provide nutritional support. So the child was supplied with FEPS, continue ART, and start CTX. So the general summary of the findings. Sorry for that. Okay. So the general examination on 13th of April 2021, the child was tested positive and was started on ABC3TC, LPVR, and INH. And on 29th of November 2021, the viral load was at 1,845, that is 6 months post-initiation. Then on 25th March 2022, the viral load was 22,927. So despite the EAC, the viral load was still high because of adherence issues. So on 24th of August 2022, the viral load came out TND, and therefore the child was transitioned to ABC, 3TC, and pediatric DTG. On 24th of November 2023, the viral load came out very high, 236,772, and this was a period when the child was being given monotherapy. And on 28th of March 2022, the viral load was less than 40 copies. So our question as a facility are that, first question, how best can we improve on provision of family-centered care in order to enhance pediatric retention on care for pediatrics with HIV negative caregivers, e.g. the grandmother in our situation? The second question is, how best can we improve the quality of EAC sessions for the pediatrics to ensure, to enhance adherence and retention? The last question is, how best can we engage the father to take responsibility over the welfare of his child despite his nomadic and social lifestyle? I end my case. Thank you.
Thank you so much, Mr. Changwe and team, for putting up this good case and also presenting it very well. You were very clear. I'll just summarize the case before asking the participants to share their thoughts. And please remember, you can also post your thoughts in the chat box. So we'll start attempting question 1 just after my summary. So this was a case of RN female 10, who was diagnosed shortly after her mother passed away in 2021. So her father remarried and seems to have marital problems, but also was listed as abusing alcohol. This child has been moving between homes since the father remarried, and child lives between the grandmother and the stepmother. And it was noted that while with the stepmother, the child would not adhere to treatment. And the stepmother was also giving the child monotherapy, which is pediatric DTG. And so the last review showed that the child was also malnourished. This was in November 2023. However, currently receiving nutrition support in the form of HEPs. So the team would like to know, the good news is that the child is currently suppressed, but the team has these sets of questions that are before us. Question 1 being, how best can we improve on provision of family-centered care in order to enhance pediatric retention on care for pediatrics with HIV negative caregivers, that is the grandmother. So any takers for question 1 before we invite our panel of experts to also give us their thoughts? We can have maybe 2 unmuting, and then we'll read two comments also if there'll be any. So in our facilities, what are we doing? I'm sure this case is very familiar. If we have a child who's on treatment, and we've just been told in the didactic presentation that it's important for us to utilize family-centered reviews. So what do we do for these caregivers that actually HIV negative? There's a question also to the team from Chinga province, from Dr. Mwinga. Did we do a CD4 count for this child? I think that's an important question. Or kindly shed some light on the kind of TB screening done at the last review with the noted malnutrition. Then the second question, please, these are not only for Mr. Changwe to answer. I believe the whole team from Kumba Rural Health Center is logged in. Let's assist with the answering. So did we do a CD4 count? Then could you also explain the type of TB screening that was done on the last review? Then the second question is, at what stage was disclosure done to the child? Could you just respond to these for now?
Okay, thank you very much. So on the issue of CD4, it wasn't done. Then on the part of disclosure, so disclosure, we have done partial disclosure. The child is not yet mentally reached the stage where we can do a full disclosure and take full responsibility over her care. So we are doing partially. So we haven't reached the stage where we have disclosed fully because of the mental developmental stage of the child. And I don't know if I've missed one. I think I didn't get the other question. The question about TB, I think. So TB lamb came out negative. I think I just forgot to include that on the investigation. So TB lamb was done, then came out negative. Thank you very much.
Okay, thank you. So any other questions before we start attempting to answer? Mungomba, supplementals training. You can unmute and give your comment.
Good afternoon, team. So I think the question here is that was the genotype done in this child living with HIV? Because, you know, of course, from the look of things, this child is actually suppressed. But, you know, mutations can be archived. And one thing we know is that if the resistant mutation of the virus is actually less than 20% of the total viral population, it cannot be detected. So was the genotype done in this patient? And if it was done, how easy is it, you know, to do genotype in this region? Thank you. So, sorry, this is Dr. Mwale from Mundola. So we have a mentorship training here. So it's quite a huge group from my background. Thank you.
And noted. Thanks, Mr. Changwe. Are you able to respond to that? Did you do a genotype? I know you mentioned that urine lamb was done and it came out negative. Okay, maybe also a comment on what made you fail to do the CD4 count?
Okay, thank you very much. So on the issue of genotype, it wasn't done because if you look at the investigations, the viral load, so the main issue was the issue of adherence and how to retain this child. So we wanted to focus on maybe wanting to retain this child. And when you look at the investigation, there is a point where this child reached TND. So it could be that there is no resistance, but only the issue of adherence and retention to care of this child. That is on the genotype. I think there is also another one there on the CD4. I think we just missed that one. So I'm sure as the child comes through, we are going to make sure that we also check the CD4 count.
Okay, thank you. Could we just attempt answering the questions the facility has before we hand over in just like 2 to 3 minutes from the network? You could tell us any question you're attempting here among the sets of questions that have been asked. Then you give us your thoughts. How best can we improve the quality of EAC sessions for pediatrics to enhance adherence and retention? How best can we engage the father to take responsibility over the welfare of his child despite his nomadic and social lifestyle? Yes, Kelvin from Chinsali, please unmute and give us your comments.
Thank you very much. Good afternoon. If I may be allowed, I will just summarize my contribution maybe to probably all the 3 questions with the ideas I may have, with the good work which has been done by the facility, which I have to acknowledge. When we look at the first question, I think this is something maybe the facility has even tried to do. One thing which can help us is just to enhance on the information dissemination concerning the HIV package in relation to any member of that particular family who may have it, and now specifically a child because it's a special case. So when we identify situations like this where the one who is taking care of this child is HIV negative, they really need some very good counseling where you need to clear the myths and whatever they know in terms of how HIV is transmitted. So all the basics here have to be taken into consideration. This family really needs some good time of talking to them. Both a professional counselor as well as a clinical staff would be ideal to calmly speak to our grandmother and just share how best the grandmother can take care of this child, and looking at the social life and how she's able to manage to take care of all the things we may look at to actually improve even the nutritional status of this child. If it be possible, linking them to other departments away from health, that would really help. Then when we look at the second question, how best can we improve the quality of ear accession for pediatrics to enhance adherence and retention? It is starting from the first question, actually. If we do a very good job with the caregiver who has given themselves to take care of this child and understand the HIV infection and everything, and we remove all the negative things they've heard about it, thinking they may get the infection just maybe by associating with this child, and losing the hope that maybe there's nothing else which can be done to actually have this child grow up normally like anybody else. If those things are dealt with and explain the importance of medications the child is supposed to take and for how long this has to be taken, and also the monitoring issues has to be very well explained to the guardian, because at this age this child is dependent on any guardian who's been given this responsibility. Unfortunately, we see that the father is having these issues, which has been explained. This is something which is not very easy to do. I have to mention to the team to deal with parents like this. But with time, as you continue to engage them, and if you try to assess this father and also just screen them nicely, you may find that you may need to link him as well to some other services which can maybe can be of good help to just change his kind and type of thinking. If at all he's not having the HIV itself, if he's having HIV itself, maybe you need to connect this one to some psychiatric department where he may need to be helped, and other organization in line to help us achieve this goal. For now, that's what I can contribute. Thank you.
Thank you so much, especially for even attempting each question. At this point, I think I'll ask the panel of experts to also come through, since we are really running out of time. So if we have Dr. Khozya, Dr. Chimika, Dr. Manzi, Dr. Banza, for our pediatricians on the call, please, could we just give some guidance to the team? They need to get take-home messages that we should make a follow-up on later on, based on your advice. Chalilwe, if you're on the call, please come through and give your thoughts.
Hi, Dr. Chipasha. As maybe as the others are getting on board to the question, I think one part that could be used to help the mother or this grandmother, this granny, to help enter the treatment and counseling is that if there is an experienced client within that community where they're living, this is a client that would actually be, this is a caregiver that would link to that client. So they can offer some support within that community. Another part would be if you, I don't know whether Shimanda has any services, any OBC services. These OBC services do provide quite a good way and platform to engage with the caregiver, where these caregivers can actually be visited by community healthcare workers to provide some care and adherence support. If that is not possible, it would be good to see how best we can link to other supportive services. Yeah, so another part would be to see if we can have an older sibling or someone younger that is living with this child. I know granny might be the breadwinner in that house, but there might be someone that is around 18, 19 that is able to care for this child. That would be nice to train that person to offer that support to this client, so that they can easily come to the health facility and easily communicate with this child. I think that is my input on this case.
Hey, thank you, Dr. Mando. So we also have some comments in the chat from Mungomba Fragmentus Training. Clearly, this child has an unstable caregiver as the facility keeps on engaging the father. Other caregiver, perhaps a CBV, may be engaged to implement daily observed ART. This child may need a very committed CBV. Okay. The other comment I read also was in line with what Dr. Mando is just talking about, which is linking the child to ICAP 1. Sorry, I just seem to have lost the comment for some reason. The comments are disappearing, but I did read the comments and probably agree with you, just as Dr. Mando has also highlighted. So Pumba Rural Health Center is taking note how best we can improve on the provision of family-centered care. I think we got that comment which was talking about the caregiver coming with the child for review, regardless of them being HIV negative. Okay, so okay, we have hands from Dr. Chimwemwe Zulu, then we'll have Dr. Chimik also coming through. You can go ahead, Dr. Zulu.
Okay, thank you very much, Doc. So I think most things have already been mentioned. And I think the 2 points I just want to emphasize on is maybe one in particular. I think the issue of this father being an alcoholic, I think we really need to pay particular attention to mental health. It's something which is being talked about again and again. And this is a father, remember, who's also a recipient of care. We didn't go into detail about finding out how he is doing. Is he suppressed as well? Do we have issues there? So I think that's an issue that the team can take away to just also, can we make sure the father also is taken care of? Because alcohol abuse leads to mental health issues and worsens the progression of HIV. So let's see how best we can help this father as well, even as we seek to help the father and we're able to get him to a place where he can not be an alcoholic. I think it will better the family. Then also just to mention, I know we skimmed through it because of time, but to go back on the issue of TB screening, Dr. Mwinga had brought up how we screen this child. So let's just remember also, I think TB lab on its own is not the only thing we use for us to investigate this child. So this child has got malnutrition, which is one of the most common signs of TB in a child. So we need to make sure if we have access to a chest X-ray, you do a chest X-ray. This child is 11, if I'm not mistaken. We can get a sputum, take that sample for gene expert, and those will give us also some more information even beyond the lab. Let's not just do lab alone. Let's do all the investigations necessary. So I thought I'd just echo those two, but otherwise, a very good presentation and a very good contributions from the team. Thank you very much.
Thank you so much, Dr. Zulu. You've also been contributing throughout the presentation. We appreciate your continued support. Yes, Dr. Chimika, please come through.
Yes, good afternoon, everyone. Thank you, Chair. And first and foremost, I want to commend the team for sharing excellent cases that have brought out quite a number of issues that raised very productive discussions. I must mention that as a pediatric HIV program, I think we've been talking about and appreciating that the program is lagging. When you compare in terms of performance against the 95 targets for under 15, we are not doing very well, okay? And this today's discussion actually brought out some of the contributing factors. And I congratulate the team for selecting those cases that have actually brought out key salient issues that contribute to this. So what I encourage and remind everyone is that each time you come into contact with a child that is HIV infected or affected, indeed, this is orders for those that are HIV exposed infants and also the infected children. Remember, the provision of services or for them to access the services that we put in place is dependent on the caregivers, okay? So we need to ensure that we don't just focus on the child. Let's try or strive to assess the family dynamics, the welfare of the caregivers. Many of them may have genuine reasons, right? Could be genuine reasons, there could be genuine barriers that could make them not come and bring the child to the facility for the clinical pharmacy appointment or indeed lab appointments. So this is where we need to assess if they need help. I think that's Dr. Mando shared nice representation in terms of the available resources that you can tap in, organization that can come in to support such families. It all starts from there. We don't have to wait until the child misses appointment. That's when we discover, oh no, this family is, they don't have, they have financial issues, or the father is a drunkard, or the family the unit is not stable. So I encourage everyone that as we enroll this child into care, let's also look at the family dynamics, okay? The success of treatment for the child will depend much on the family support or the caregiver support. So let's address if there are any issues from the caregiver perspective, right? And then I want also to remind everyone that we have a global call, which we have, Zambia has subscribed, and we have this Global Alliance to End AIDS by 2030. What it means is that is in children, and a Global Alliance to End AIDS in children by 2030. What this entails is that we need to ensure that measures are put in place to reduce or eliminate all those factors that can lead to a child developing AIDS. And one of them is making sure that those that we have enrolled into care or treatment are retained, because when they miss an appointment, we don't know what is happening to them. They may not have tablets to take, okay? And you know that at certain ages, the progression
to advanced HIV disease or indeed risk of developing AIDS are high. And for us to achieve that, we need to ensure that all measures are put in place, which Dr. Mwinga, I think, has well articulated, and also Dr. Mando well articulated in terms of some of the best practices that are available that we can tap in and make use of, right? Otherwise, let's ensure that when we have an opportunity, child comes through on every visit, let's ensure we interrogate the caregiver dynamics. Okay, previous visit, maybe things were okay, but this time maybe the caregiver has changed, or indeed maybe there's some conflicts in the family that will affect the success treatment of this child. So I wanted to summarize it that way. Otherwise, well done, team. Thank you very much.
Thank you so much, Dr. Phiri. Looking at time, I'll just try to summarize the responses for the sake of the team, because you have to document these, and we'll make a follow-up on the progress on this child. That's the importance of it documenting, so that when we ask for feedback, you please speak to the recommendations the experts have given. So for question 1, we can see there's advice regarding reviewing the child on pediatric clinic day and with the caregiver present. And then there was a mention also of what I believe the person was commenting was trying to hint on the caregiver support groups, where this caregiver will be mingling with other caregivers. And so that also helps in the case of caregivers who are HIV negative, but they're caring for our children living with HIV. Then regarding probably both question 1 and question 2, the guidance that has been given by Dr. Chimika, which is we need to really understand the caregiver dynamics, even as we are talking about quality of EAC sessions, because the person who's receiving that session with the child present also has to be of, can say, sober state, for lack of a better term. If they have issues of their own, they should be assisted also to handle those issues. And then we also have to ensure that we have trained staff who are offering these EAC sessions, opposed to delegating the task of EAC sessions to CBVs. I think this has been found time and again that our EAC champions are actually our support staff, and trained staff don't even know what's happening with the child. So let's encourage trained staff to be part of the EAC sessions, to know what's happening with the children. There was also an advice also regarding to question 2, that we conduct DOT. We probably have to some form of directly observed therapy. At this point, we can even assign a CBV, since we're still looking for a more reliable caregiver for this child, who will be watching the child swallow the tablets, and ensure that they are, yes, adhering to treatment. It's good to note that in your presentation, you say the child is currently suppressed. So we know there's something that you're doing that is working. And so probably we need to just maximize and optimize whatever it is that we are doing, since we've managed to suppress the child. For question 3, as Dr. Zulu mentioned, the father needs to be linked to mental health services or facilities that will be able to also address the issues that you have brought out. But she also encouraged that we take a step back and also look at additional things that we might have missed. You mentioned the alcohol abuse, but in terms of how he's doing on ART, I think that didn't really come out on the presentation. Yet we've had a number of experts actually encouraging us to also take note of how the caregiver is. So for our father, it means we should take interest in the ART as well. How is he doing? Probably link him to appropriate services if it's EAC that he needs, SITA program if you have it, or mental health evaluation, so that he's in a better position to also take care of his daughter. Okay, so maybe just an addition would be that even as we're talking about a father who's nomadic, let's also see how best we can engage a stepmother who was mentioned as not adhering to treatment, or ensuring that the child is adhering to treatment. Let's not demonize her, but we try to bring her close and just try to understand what challenges she's having. We have seen the dynamics between stepmother, stepdaughter, and so we shouldn't be quick to judge her. and assume that she's just in the wrong in all this. But we probably also have to understand what she's going through and try to make her a plan together with herself and the child and probably the grandmother present, possible even the father present. They all sit down and then we talk about the welfare of this child, make a plan as a family that will benefit the child. Yes, so those would be my my ending points or summary based on the feedback that we got. I'm sorry we couldn't really go through all the chats. I hope I've tried to summarize the feedback that I read through the chats, looking at time. So could you just give us feedback as Mpumba Rural Health Center if your questions have been answered?
Okay, thank you very much. So as Mpumba Rural Health Center, we are very much grateful and we have taken note of the recommendations that have been shared and we are going to ensure that we work on the recommendations as provided. So our questions are answered and we are satisfied with the feedback. Thank you.
Okay, that's great to note. No, thank you so much once again for submitting this case. We are grateful, Dr. Mando, for the time taken to put up the didactic presentation, the availability of our experts. Thank you so much. All those who participated, logged in, and you're following the discussion, or you even took the time to actually contribute. We are really grateful. We cannot do this these sessions without you. We hope you continue with the spirit of just logging in and participating. That's how we are going to build capacity in one another. As from me, your facilitator, say thank you and I hand over to probably the coordinator at Ambuyo. Thank you.
Thank you very much, Dr. Chipasha. And thank you everyone for the participants, the presenters. That was a very interactive session. So I don't have anything to say, just encouraging people to join. We have another session tomorrow. It's an awareness from the hematology team. We'll have it from 12 to 13 hours. So people should look forward. They've got something to share with us. They're raising awareness. If there's nothing, if Dr. Chimka gave his, Dr. Mando rather gave his closing remarks, I think we can call it a day. Otherwise, thank you everyone for sharing. Over to you. So everyone have a good day and see you tomorrow. For those who have time, please log in for a special echo session that we have. Wishing you a lovely day. Bye.
Thank you.